Hello, my name is Victoria Holloway Bullock, and I'm an acute care adult gerontology nurse practitioner, board certified. I also have my family nurse practitioner, board certified, and my DNP project is about decreasing neurosurgical consultation time in level green trauma patients. Here's the committee that makes up my project. My chair was Dr. Joanne Kern. The second reader was Dr. Boniface Stegman. And the community member is Dr. Halil Kanan. We're going to talk about the background and significance. Approximately 5.5 million people suffer a severe traumatic brain or spine injury annually, and many survivors have morbidities and even mortality with substantial costs to society. So actions taken in the pre-hospital setting focus on preventing secondary injuries, as the primary injury cannot be reversed. And so a secondary injury includes interventions to avoid hypotension, hypertension, hypothermia, hyperthermia, hypoxia, seizures, among other things that cause neuronal brain damage. And these injuries were recorded in 90% of patients who died from brain injuries, these secondary injuries. And so to help avoid these injuries, interventions to reduce consultation times in these patients have been shown to decrease morbidity in traumatic brain and spinal cord injured patients. And so at the facility I worked at, we would have trauma caring patients that would come to our facility with known neurological injuries. This is the brain or spine that required a neurosurgical consultation. Now, these patients would arrive in the emergency department, and often the neurosurgical team, which I am part of, would not get consulted, sometimes for hours after the patient arrived. And during that time, I would go down there and I would see that patients should be on spine precautions, for instance, and their head of bed, instead of being flat, is they're sitting up in bed with an unstable spine injury. This can worsen neurological injuries. I've also seen another patient who had a traumatic brain bleed, and they had been started on chemical DVT prophylaxis, so in this case subcutaneous heparin, without getting a stability scan to make sure the bleed did not expand. And we typically don't start chemical DVT prophylaxis 48 hours until after the stable scan. And so these are just two examples of several other examples that I saw that, could worsen these secondary injuries. And if the neurosurgical team had been consulted sooner and our recommendations implemented, I feel like we could have avoided some of these potential secondary injuries if our team had been consulted sooner when the patient arrived. So to review the current literature on this particular quality improvement plan that I had planned, I used Google Scholar and Dynametics. These were the primary research tools that were used to find evidence-based articles. Dynametics is a hospital search tool that was available at the facility where the QI project was implemented, and we're able to look up evidence-based articles. The themes that I grouped my articles into was neurosurgical level green trauma patients, secondary neurological injury, causes of delayed specialty consultation in the emergency department, and reducing consultation time. There are several articles that I found in these categories And many of them I used in my literature review and in doing this project. The theoretical framework that was used for this project was Lewin's change model. This offers a strategic approach that can assist nurses in planning, implementing, and evaluating a proposed change. This model has 3 stages: unfreezing, movement, and refreezing. And unfreezing, when it came to the DNP project, ED wait times would be shortened, patient throughput would improve, and secondary neurological injury could be decreased by implementing neurosurgical recommendations within 30 minutes of patient arrival. Movement, this is the second stage of Lewin's change theory model, was implemented through the algorithm. And this is to ensure neurosurgical evaluation of trauma green patients within 30 minutes of patient arrival to the emergency department. And refreezing, the third stage, included staff feedback on implemented changes, motivating staff to implement the algorithm, and incentives to change the current practice change. For this project, a quantitative retrospective chart review was utilized. The inclusion criteria included electronic health records of 154 patients. Patients were 18 to 89 years old who sustained a neurological injury that was being transferred to the targeted Trauma 1 center from a secondary care center. And these patients had a known injury that required neurosurgical consultation. Participants were 18 to 89 years old. And they were admitted for neurosurgical consultation between July 1st, 2024 through September 2nd, 2024. Some of the exclusion criteria included any pediatric patients, so any patients that were less than 18 years old were not included. If the patients had a higher acuity trauma code or trauma level, for instance, trauma yellow or trauma red, these patients were not included in the study. These patients did already have a set time that consultation had to be performed within at this facility. And if the trauma green patients did not have a neurosurgical, so a brain or spine injury, we did not include these patients. And if the patient were admitted directly under the neurosurgical service, these patients were also not included in this trial. So a sequential inclusion and exclusion process was completed until the determined 154 electronic health record, 154 patients were achieved. This is the data collection sheet. And so we just numbered each chart, chart 1, chart 2, chart 3, etc. And then we had pre-intervention, and if yes or no, if the algorithm was implemented, arrival time in the emergency department, time the neurosurgical team was consulted, and then whether this consultation order was placed within 30 minutes of patient arrival or outside of that 30-minute arrival period. This was the algorithm that was implemented in the trauma bay. It was laminated and enlarged, so it was easy to access and easy to see. And so trauma could easily follow it. So accepted a level green trauma patient with brain or spine injury. Yes, you move to the next square. Were you notified by the ED secretary of patient arrival in the ED? Yes, move on. Consult neurosurgery within 30 minutes of notification of patient arrival. And then it shows you how to place the neurosurgery consult order and call the number. Descriptive statistics were used to assess the data of the time of patient arrival to the ED and the time of neurosurgical consultation, pre and post algorithm intervention. Yes indicated whether neurosurgical consultation was placed within 30 minutes of patient arrival to the ED, and no indicated that the consultation was not placed within 30 minutes of patient arrival to the ED. And so as you can see here, the chi-square test and the upper tail z-test for the difference of 2 proportions were used to determine if there was statistically significant difference. The upper tail z-test indicated there was a significant difference between neurosurgery consultation time pre and post algorithm implementation, and thus the null hypothesis was rejected. The algorithm did in fact reduce neurosurgical consultation for trauma patients with known injuries, lowering secondary neurological outcome. Here is a more visual representation of the results. And so here you can see a pie chart, pre-intervention, the amount of patients, which in this case was 77 patients pre-intervention and 77 patients post-intervention were looked at. You can see here in pre-intervention, the amount that is in red is the patients that were not consulted within 30 minutes of patient arrival to the emergency department. So this is sometimes, majority of the time, an hour or more, even a few hours after arrival, that patients were being consulted. But when the neurosurgical consultation was placed, the order was placed. Now you can see post-intervention, the green represents the amount of patients that neurosurgical team was consulted within 30 minutes of patient arrival to the emergency department. And then the red again represented no, or that patients that were outside of that 30-minute call. And then this is a picture of the actual algorithm that had been implemented in the trauma bay. And it was posted in the trauma bay as a big laminated algorithm on their wall, and it's accepted level grade trauma patient with brain or spine injury, notified by ED secretary of patient arrival in the ED, consult neurosurgery within 30 minutes of notification of patient arrival, and then place neurosurgical consult order, and then call the number. And this is an easy way for trauma physicians and trauma residents to look at this algorithm very quickly and see what kind of patients and how to consult the neurosurgical team and within what time frame. Here is table 1, which shows the upper tail z-test for the difference of two proportions, and this is the table that has the statistical data analysis displayed. Like any quality improvement project, there were some limitations. So this particular project had a short study duration. This could have led to an overestimation of the effect. Studies with a longer duration of study with data collection could help mitigate this. And then another limitation is the inclusion criteria for the subjects were pretty restrictive. This study only applied to trauma green patients that were incoming transfers from outside hospitals with imaging that confirmed a known brain or spine injury that required neurosurgical evaluation. This study was not applied to trauma green patients that were diagnosed at the hospital of study, and thus these patients were not included, which may have in this study, which may have changed the study outcomes. To mitigate this, just a larger sample size that would apply to incoming trauma green patients and also trauma green patients that were admitted to the ED at the current facility could mitigate this. And this would yield a much larger sample size and represent a population more appropriate for the surrounding community and may provide more accurate results. Implications for practice. Implementing this algorithm into practice change at this facility has the potential to decrease secondary neurological injury, improve patient throughput in the ED, which in turn will improve patient satisfaction and improve patient outcomes. And algorithm implementation is a very cost-effective and effortless way to implement QI projects into practice. And these improved outcomes that occur during this improvement project do not only have to apply to trauma green patients with neurological injuries, but this could be applied to other patients that need specialty consultation as well. This can also help tackle patient throughput, helping with hospital capacity utilization and increase productivity without further expenditure, and also improve patient outcome. And to make this study into a practice guideline at this facility, the trauma physicians, the neurosurgery providers, and the quality improvement committee at the facility would have to agree on the practice change. They would ensure all staff were aware of the permanence of the project and the implementation of the change. And the quality improvement committee would ensure compliance with new practice guidelines and ensure proper education to new incoming resident trauma physicians. Millions of people sustain traumatic brain and spinal cord injuries annually, and it can be a huge cost to society, high morbidity and mortality in these patients, and can just have bad patient outcomes. Secondary neurological injuries can worsen outcomes and morbidity in these patients. Targeting treatment to secondary neurological injury can help improve or reduce the risk and improve patient outcome. One way to combat secondary injury is implementing treatment recommendations swiftly. To implement these recommendations in trauma green patients with known brain and spine injuries, an algorithm was placed in the trauma bay to instruct trauma physicians when and how to consult the neurosurgical team within 30 minutes of patient arrival. The results of these studies showed that after implementation of this algorithm, majority of these trauma green patients were seen and had treatment recommendations in place within 30 minutes of arrival, thus reducing secondary neurological injury and ultimately improving patient care. With the success of this project, it would benefit the facility to implement this algorithm into practice. One way to sustain this is by having quarterly meetings at this facility with the trauma physicians and the neurosurgical team. Now, these meetings already happen quarterly at this facility, and so every time there's a meeting, just discussing the algorithm, remind physicians to be implementing this practice change, can ensure sustainability and can ensure continued improvement in patient outcomes. Based on this improvement project and the positive change I have seen, I am motivated to tackle other challenges in healthcare and to spearhead more quality improvement projects to improve patient care after going through this process and seeing the steps needed to implement and ensure quality improvement. Navigating the DNP program has given me the knowledge and tools to implement these improvements in patient care. It's given me more confidence in collaborating with stakeholders, community members, other healthcare team members, and even officials. It's also made me aware of breakthrough AI technology that I didn't even know was a part of healthcare and how much it's improved healthcare. It's also improved my scholarly writing, and it's taught me how to better research peer-reviewed articles. I have statistical knowledge that I did not have prior to entering this program, and it made me realize how important statistic is to research. And this program has a lasting impression on me to the point where in a couple of years, maybe even less time, I'm considering potentially being a teacher, being a professor for other hopeful doctorally prepared students, because quality improvement, patient improvement, care improvement is so important, and ensuring appropriate research to back up your hypothesis or appropriate research to back up what you hope to improve is essential in these projects. And really hoping that I do more quality improvement projects in the future. Here is a list of references used in this PowerPoint project.